The broadcast is now starting. All attendees are in listen-only mode.
Well, hello everyone, and thank you for joining us today. I'm George Wertak, Executive Director of the Consortium for Infectious Disease Control, and I'll serve as moderator of today's program entitled Accelerating Cervical Cancer Elimination, What You Can Do. This educational webinar is made possible through the support of Merck Canada and with the assistance of BD Diagnostics and Immunize Canada. And I'm happy to announce that Dr. Marc Steben will present today's educational program, and I'll introduce him in a moment. Now, in today's webinar, Dr. Steben will address the learning objectives that you will see up on your screen. And I always like to remind our audience that the webinar will be recorded and that the recording, as well as the PowerPoint slides, will be available sometime following the webinar. They'll be archived on CIDC's website, and you can see the address on the bottom of your screen there. This video recording, along with recordings from other webinars and additional useful resources, can be found on the CIDC website. And you can also join the HPV network by completing the Contact Us form online. Okay, so a few housekeeping notes. First of all, participants have all joined in listen-only mode, so you can hear, but you won't be able to ask a question verbally. But you can type in a question at any time, and then just click the send button. You can hear the audio either with computer speakers or by telephone. If you have sound trouble with computer speakers, you can select the telephone button and then dial in with the number, and access code will be displayed. The questions will be saved, and all or some of them will be answered following the presentation during the question and answer period at the end of the webinar. If we do not get through all the questions, Dr. Steben has agreed to try to find time to answer at least some of them in writing, and these will be posted on the CIDC website. In terms of the slides, again, the webinar is recorded. The slides and the recording will both be available on the CIDC website. And we hope that all participants will complete the webinar evaluation. You can see the link for this evaluation survey. And if you registered with your own email address, you'll be sent an email with this link. But if you did not register personally, if you're sitting with a group of others, please take note of this address. Okay, now I'd like to introduce our presenter for today's webinar, Dr. Marc Steben. You likely know that he serves as the chair of the Canadian HPV Prevention Network and that he's a board member of the International Papillomavirus Society. And he also serves as an associate professor in the School of Public Health at the University of Montreal and is also a medical consultant with the Family Medicine La Cité du Parc La Fontaine in Montreal. Marc has also been a driving force for the control of cervical cancer, and he leads a group of experts who have put together a plan to eliminate cervical cancer by 2030. So I'd like to welcome Dr. Steben.
Thank you, George. Hi, everyone. I'm very happy to be with you and talk about elimination drive toward the WHO objectives of 2030 to eliminate cervical cancer.
Dr. Steben, can you click on the slide and advance?
Yeah, I click.
There we go. Yeah, it's a little bit slow today.
We're going backward. So these are my disclosures. So most of my disclosure is about HPV diagnostic, treatment, or vaccine. So I like to start with famous quotes to inspire us in this era of cervical cancer elimination. If not us, who? If not now, when? And it's clear that if we want to achieve that 4 per 100,000 cases, this is the mark for elimination, we need to start now. And we know that cancer has a long time to develop, and the opportunities to screen and to treat is now. So we have to gear up right at this moment. And the quote was about ask not what your country can do for you, but what you can do for your country. And I would say ask not what your country's plan for cervical cancer elimination, but what you can do for your country's plan of elimination of cervical cancer. Just a small reminder that cervical cancer, of course, is a disease that has become very low in high-income countries, but still, by 2030, cervical cancer is expected to kill a little bit less than 500,000 women per year, and over 95% of these deaths are expected to be in low and middle-income countries. But we'll see that in Canada, we have our low and middle-income counties where a lot of work has to be done. And when we look at the burden, we know that women around the world are affected, and it's the second cancer, only to breast cancer, as a leading cause of cancer in women worldwide. We talk about 2.3 million women around Earth that is currently living with cervical cancer, and nearly every minute of every day, a woman is diagnosed with cervical cancer. So our objective today, discuss WHO goal, address elimination from a prevention perspective, talk about the challenges that we have with the current cervical cancer burden, and finally to talk about the recently produced document about Canada's role in accelerating global elimination. Sorry for that. In Canada, we have one of the best programs in terms of vaccination. We know that NACI, the National Advisory Committee on Immunization, made wide recommendation about the use of HPV vaccine, starting from age 9 and whatever age you are, you can have the vaccine. So NACI did remove the upper limit of age that the company had when they do the study. If you need protection against HPV, you should be able to receive. And that would be equally for females and for males. So we're gender neutral recommendation across Canada that is make us one of the best implementation plan for HPV vaccine around the world. Recently, I've published some review of the impact and effectiveness of the quadrivalent human papillomavirus vaccine. And we had to review 7 eligible studies. And these 7 studies were done in 5 provinces. And we looked at 3 different outcomes. The first outcome was HPV infection. Second one was HPV-associated anogenital warts, and the third outcome was HPV-associated cervical dysplasia and cervical intraepithelial neoplasia. So results are unanimous, I think. We have a very good proof that these programs that we've set up in 2008 and forward are delivering what they were built to deliver. In Quebec, we had a study about HPV infection, and we were able to see that between young adults that have been vaccinated compared to those that were not vaccinated, there was a decrease of at least 86% for the 4 HPV that are in the quadrivalent vaccine. If we look now at the anogenital warts, we saw a decrease of about 40% in Manitoba, 43% in Ontario, and 45% in Quebec. But what was quite astonishing in Quebec, that decrease of 45% was seen within 3 years of the inception of the program, knowing that those populations that were targeted at the start were very low risk in terms of sexually transmitted infection. We see it delivers rapidly. And when we look at HPV-associated high-grade lesions, we saw a decrease of 44% In Ontario, 52%. In Alberta, but 86% of CIN2 plus in BC. So 7 different publications showing high efficacy and return of our HPV vaccine program. But we have to be careful. And if we see from left to right, a decrease in the coverage rate of HPV in various provinces, so almost 89% in Newfoundland, and we see decreases to 39% in Northwest Territory. But if you look very closely to Ontario, we had 80% in coverage, and the year after it was 61%. So we have to be careful that we don't see that difference appear. We have to be careful. The success we have in terms of coverage can be very fragile and certainly at the mercy of one more fake news that would circulate on the social media. So pretty good performance across Canada, but some result could be more fragile than we would like it to be. And also with the vaccine, now we have the long-term follow-up studies with the quadrivalent vaccine. So we know that we've seen no breakthrough cases. So we have 10 years of follow-up for boys and girls aged 9 to 15, 12 years for women aged 16 to 23, 10 years for men 16 to 26, and 10 years for women 25 to 45. And we see in those long-term follow-up study, no breakthrough cases have been found. And there's now one long-term follow-up study for the 9-valent HPV vaccine, and it's 6 years for boys and girls aged 9 and 15. And again, there's no breakthrough cases in that long-term follow-up study. Also, we know that our surveillance program are very good in Canada, and I'm going to show you a few examples. So one is the evaluation of the risk of autoimmune disorder in the Ontario grade 8 HPV vaccine cohort study. And they did not observe an increase of autoimmune disorder following HPV-4 vaccination among teenage girls. And this should certainly reassure parents and healthcare providers. Also, there were doubts that boys and girls that would be immunized would adopt highly risky sexual behavior. And on the contrary, we're able to see in that same surveillance program in Ontario that there's strong evidence that the HPV vaccination does not have any significant effect on clinical indicators of sexual behaviors among adolescent girls. And the two main indicators were pregnancy and non-HPV related STI. Also, what we saw is the absence of herd protection as was seen in Australia. So in Australia, they were able to show a strong herd immunity. Boys that were not immunized were getting protected from the fact there was high coverage of vaccination in the female population. And we see in Ontario and in Quebec, we have the same. We don't see the appearance of herd immunity, and that is why now Canada is fully gender-neutral vaccination. So we have a program for boys and girls. When we look at the communication issues, we did a survey with the Society of OBGYN of Canada, and we're able to look at the top part of the slide at physician, how they answered some question, and the bottom part, they're adult women who have been vaccinated, women that have not been vaccinated, and males that were not vaccinated. First panel showed that most GPs administer and recommend HPV vaccine, and customers say doctors are trustworthy source. So we have a good start in terms of advocating for the HPV vaccine. In the middle panel, physician and consumer agreed that vaccination is an important aspect of disease prevention. And the last panel shows the difference between physician and consumer. Concern over vaccination safety is low among physicians, however, higher among consumer. And when we look at the reason people are not getting immunized, physician tells that cost is an issue, is a barrier to the HPV vaccine. And this is mostly on the side of physician. This is not seen as highly on the side of consumer. in the middle panel, consumers are more knowledgeable about HPV than physicians would believe. And consumers say recommendation and discussion would motivate them to be vaccinated. And when you look up, you see how frequently conversation is happening when we ask OBGYN and GP, but you look at the bottom and see how little information consumers receive from the physician about HPV immunization. So there seem to be little differences between what happens in doctor's world and the consumer world. So there's a gap in terms of communication about HPV vaccine. And we know that there's something bizarre with this vaccine. Primary care doctor treat differently HPV vaccine from other routinely recommended immunization. We don't know why, but it's not the same. Hesitating to recommend it fully and on time. So usually the recommendation will be soft or lukewarm, but certainly not the same level that we would for other adolescent vaccination. And we know that in surveys, the single biggest barrier to increasing HPV vaccination is not receiving a healthcare provider's recommendation. That's more of an issue than parents' decision to refuse or delay HPV vaccination. So there's something we need to be aware that communication has to be much stronger than it is at this moment about HPV vaccination. And we know that, so in Quebec, we have a workshop, accredited workshop, 3 hours. We're looking into translating it, and it's about words and facts to optimize the use, to improve the use of HPV vaccine. And I think our counseling should remain very simple. More the message is simple, better will be the understanding of the patient. And we know the HPV vaccine is effective, safe, and is recommended by all professional societies in Canada. So keep our message simple, that it's effective, safe, and recommended. Some people will say that, well, we don't have the proof that this vaccine really provides protection against cancer. But now Finland had produced a report that has been published in 2018. And you see in the left column, we have HPV vaccinated women, and we see no HPV-related cancers, cervix, vulva, oropharyngeal, or other HPV cancer. And on the right side, you have non-HPV vaccinated women, and we see that there's a difference between the two columns. And we've been made aware that Finland is going to be publishing soon 2 years more of cancer surveillance and coverage of HPV vaccine. They still don't have a single case of HPV-related cancer since June 2007. So very good impact on cancer that is already measurable. We thought it would be taking 25 or 50 years before we're able to measure that, but we can see when the country is very well organized in terms of surveillance of cancer, we see the difference, and it's a major difference. And when you look at the value of the vaccine, sometimes people say, well, this vaccine costs a lot. Well, you have to differentiate the cost and the value. If it costs a lot, but it delivers a lot, I think this is value, this is not cost. And when you look at the number needed to vaccinate to prevent a single case of disease with the 9-valent vaccine, we're able to see that to prevent 1 case of cervical cancer, we need to vaccinate 165 women. If you want to prevent 1 case of anal cancer, you need to vaccinate 816. If we look a little bit lower for high-grade disease of the cervix, to prevent 1 case, we need to vaccinate 4 women. So this is incredibly good ratio. Genital warts, we have to immunize 9 persons to prevent 1 case. And when you look at men, you need to vaccinate 1,937 people to prevent 1 case of anal cancer. And again, 9 persons to prevent 1 case of genital warts. And this is all additive. So you look, there's value not only against 1 cancer, but against many cancer and many disease states such as lesions of the cervix picked up by pap smear and genital warts. So we're only starting to understand the full value of HPV vaccine. And of course, the biggest value is with the prophylaxis to prevent new infection and transmission, so youth and adolescent, as much as possible with sexual debut, but also adult women and adult males who are celibate, who've turned from a stable relationship to being celibate. So prophylaxis is certainly very good, safe. But we have to remember that the screening that we can do, the measure to prevent the effect of HPV is of limited value. So we know secondary prevention is a protection you get after potential exposure, and it's about limiting the consequences of acquiring HPV. And we know there's no screening test for HPV as we do for HIV before engaging in condomless sex. There's no epidemiological sexual contact treatment as we do for partners of patients with gonorrhea or syphilis. There's no post-exposure prophylaxis as we have for HIV, and we have no pre-exposure antiviral prophylaxis as for HIV. Also, we know there's no test of cure we can apply for someone who had a lesion or an infection. HPV test is for high-risk HPV detection, and it's mostly for the prevention of cervical cancer and not for the prevention of transmission. And pap smear screens for complication of persistent high-risk disease and not for infection. And we know that most people with HPV infection are asymptomatic. Also, I put this, it's about the natural history of an HPV infection, and we understand now with better diagnostic tools that this is changing a lot, especially the right side of the history. So we thought that most people have sustained clinical remission. It's true, but it's not true at the same time. And in fact, persistent or recurrent disease might be minority compared to those with clinical remission. The problem with that clinical remission is that the antibodies you will develop against an HPV that you'll get rid of is type specific. And this is also not present in the long term, and it's not protected against reinfection or new infection, even with the same HPV genotypes. So even in stable partners, you have the risk of retransmitting between the partners. And we know that the immunity that we're developing against HPV is rather weak, and women might develop this immunity for about 50% of the time. So 50% of the women getting rid of their HPV will not have detectable antibodies circulating. And when we look at heterosexual males, this ratio is about 20%. And men having sex with men have no lasting immunity from getting rid of an HPV. And that is why there's value in immunizing people who have had infections or lesion. That's going back to the messaging. I'm sorry, because I think there was one slide that was not at the right place. So secondary prevention, we enter secondary prevention. And we know there are limits on the screening with cytology. Very good studies that have been done in Canada and around the world shows us that screening with cytology is very good at the population level, but certainly not at the individual level. And these are an audit of a few countries of high income that look at women that were diagnosed with cervical cancer. What was their history in terms of previous screening? And we know between 50 and 60% of women will have had no previous screening or too far ago to be protective. So up to 60% of women diagnosed with cervical cancer did not have cervical cytology as is recommended to be preventive. We also have about 20-25% of false negative. So pap smears are not perfect, and we look at why they would be false negative. 2/3 might be because of poor sampling, and 1/3 might be detection error made by the technician. So this is a This is a screening that needs human eyes that are pretty sharp at detecting subtle changes in the cell, and very few cells could be affected. So it's explainable to have false negative because there's human error in terms of collecting and in analyzing the sample. 8 to 15% is inadequate follow-up. Women don't go for the follow-up, or they're not recalled because they have abnormalities. And then you have little proportion for treatment failure, and also rapid evolution of cancer, mostly related to HPV-16 and or 18. So there are big limits on screening with cytology. And we know at this moment, with this population that has been immunized entering the age to have a cervical cancer screening, that we will need to be careful about screening, because as the number of women having the HPV infection goes down, there's also a drop in the specificity of the Pap smear, and the predictive, the positive predictive value will go down. And the major risk of that is that we're going to be sending women to colposcopy who don't have a disease. So Pap smear is entering an era where we're risking to create more problem to women than saving problem to women. So there's a need to look at a diagnostic procedure that would have a better positive predictive value. And also, we'll need to change our screening guidelines. We know that vaccinated women will have less lesions, and instead of starting at 25 or 21, there might be limited value starting before the age of 30. And in Italy, they changed their screening guidelines to rescreening negative women to a longer period than for Pap smear, maybe up to 10 years. For non-vaccinated women and for women vaccinated in their 15th year or later, the current protocol should be kept for a while. So we will need to revisit our screening guidelines for those women who have received the vaccine. And if we look at the sensitivity and specificity of hybrid capture compared to cytology or code testing, like is being done in the United States, we see that the sensitivity for cytology is about 70%, but has been shown as little as 55% in CCAS study with a specificity of 91%. Hybrid capture is a test where we're looking for nucleic acid, and we see that the sensitivity is 90% and the specificity 88%. And the co-testing, where you do both tests, 94% sensitivity and specificity at almost 88%. So that's for SIN 2+. But if we limit our examination to CIN 3+, we see a little bit higher rate of detection. Cytology has a sensitivity of 74%. Hybrid capture is at 95%, and code testing 96.7%, but about the same specificity. So we see that HPV screening has potential to take over cytology as a screening test to prevent cervical cancer. So at this moment, we hear people say, we don't need vaccine, we have Pap smear. Well, this is not necessarily how you do that analysis. We know that primary prevention has been done by the prophylactic vaccine will always be better than screening. First, screening is only for cervical cancer. We don't have screening for vulvar, anal, vaginal, or oropharyngeal cancer. So if you compare, primary prevention is always cheaper, more equitable, more efficient, and more accessible than secondary prevention, in this case with HPV screening for cervical cancer. And, you know, we can always argue that we don't need seat belts and alcohol laws and driving laws because we have good emergency rooms and ambulance. That's nonsense. We need the seat belts. We need the alcohol laws and driving laws. So primary prevention is complemented by secondary prevention. And we would say we don't need condoms anymore because we have good HIV drugs. Again, it's nonsense. Primary prevention is always better than secondary. And in the case of HPV, we certainly recommend that both programs are available depending on the population to be reached. And for those people that have been exposed to vaccine-related HPV type whose infection has cleared, we know that receiving the vaccine is something that will protect. We've seen this in the 4-valent trial, where we were able to see that those women who had CIN of any grade who received the quadrivalent vaccine had no recurrence of disease. And when we look at women that had received a placebo, we see that they had 7 cases of the disease. And if you look for external genital lesion, again, those women that had received the vaccine compared to those that had received the placebo, there was difference showing that there's efficacy against recurrence of disease with the same vaccine HPV types. Is it reactivation or reinfection? We don't know yet, but still they don't develop lesions. And what about these women that are treated with CIN2-3 lesions? So we had this study done by Dr. Kang and published many years ago, showing that the risk of recurrence for women receiving a LEAP for CIN2 plus lesion of the cervix was 2.5% compared to 7.2% for women without vaccine. And the study recently has been replicated in Italy, where they were able to vaccinate half the women and follow women that were not vaccinated for half the women. And again, we're able to see the reduction in rate with vaccine of 81%. So this does not imply a therapeutic effect, for sure, but certainly underlies its role as an adjuvant to surgical treatment to prevent recurrence of the lesion on the cervix. So adding to the prophylactic aspect of the vaccine, we know that this vaccine should be considered as part of therapy, HPV positive women in screening, post-treatment of CIN lesion. We have cases in recurrent respiratory papillomatosis where vaccinated people had less recurrence, and patients with genital warts had less recurrence of genital warts or HPV lesion at other sites. HPV cancer survivors certainly could benefit, and we know that studies are ongoing with therapeutic and mixed vaccine. If we look also at the HPV vaccine efficacy in mid-adult women, of course we don't have the same efficacy as we see in young people that have not been sexually active, but still in bold blue you'll see those results that are statistically significant under the condition of the trial. And we see what the 4-valent, that there was a vaccine efficacy for against 6-month persistent infection of almost 90%, CIN2 plus of 83%, external genital lesion 95%. And you see in the various protocol, we see there's value. So certainly we have to see a value for HPV vaccine in the mid-adult women, not only young boys and young girls. So this brings us to a concept that might be interesting in the future, especially for those that are high risk and very difficult to reach by our program. So we see that in our countries, we see that what is usually recommended is vaccination previous to sexual debut. Then there's catch-up population. After that, you have a cytology every 2 years, and you stop at 65. What is the concept developing in Europe at this moment is that we're immunizing school-age cohort, we have catch-up, and then we have HPV tests every 5 to 10 years. But for high-risk and hard-to-reach population, it might be interested to have catch-up in women until maybe age of 45 and male vaccination, and to have maybe an HPV test 2 or 3 times lifetime. So the screening program for high-risk population, even in high-income country in the near future might be we vaccinate until age 40 or 45, and we do 2 or 3 HPV tests lifetime. So we have the right column now to show the full value. So for high-risk groups, and we have to remember that if we want to make stride toward that elimination goal, it's mainly in the high-risk groups. We'll have to make better efforts. So we know that people with HIV are immunodeficient and will have more infection, reinfection, and transmission, and of course, disease. Men who have sex with men much more than the heterosexual population, or women having sex with women. We know that people that are transplanted and immunosuppressed have very high rate of disease and complication. Patients with autoimmune disease, mostly those that have drug lowering the immune system. In SCI clinic, and partners of HPV positive, migrants and marginal population, and abused children. So we have to make better efforts in the high-risk group for elimination of cervical cancer. And before going forward, just wanted to let you know there are resources if you want to look at HPV testing in a Canadian context and HPV-based cervical screening. So those are previous webinars we had. And also, a lot of people are very shy of switching to HPV testing because it will change the paradigms from looking for abnormal cells to a sexually transmitted disease, and it's not the same counseling you have to give for patients who have positive results. So there's a booklet you can also download about counseling patients, about HPV test results, about transmission screening, testing, and vaccination. So I'll go and describe a little bit more the cervical cancer burden as is the case in Canada. So we know in 2016 we had 1,500 new diagnosed cases and 400 deaths, meaning that 1 Canadian woman dies of cervical cancer every day. These are the HPV-related cancers, and you see that the only cancer that is going down is cervical cancer, and we've picked up steam a little bit. So we had leveling data, and we see that we started again to go down with cervical cancer, but all the other cancer, as you can see, are increasing, and we have like oropharyngeal in male and in female, vulvar in female, penile, anal is increasing, and vaginal cancer is usually a complication of cervical cancer is going down. And you see that only one of those cancers can be screened. So we need much more than cervical cancer screening if we want to decrease the burden of HPV disease in Canada. And you see the potential trends for cancer. We have an aging population, we have a population growth, and also we have a lot of people that are entering Canada that have never been screened in the past. So there's a tendency for cancer in general to increase because of the aging and the population growth. But if you look at the prediction of elimination, what's very happy is cervix now is 16th in terms of incidence in Canada for women, and it has the best profile for elimination. It can be prevented, it can be detected, the incidence is going down, the survival could be better, and mortality is much better because we screen and we detect disease earlier. So we are with cervical cancer in a good profile of cancer to be eliminated. And I'll talk just a little bit about Canada's role in accelerating elimination of cervical cancer. I think our major problem in Canada is that we have those pockets of inequity with regard to cervical cancer prevention, and it's usually the same pockets as for all the other health prevention services. We know that these groups are usually not reached by HPV immunization nor cervical cancer. So we have to be very careful and look with community leaders how to bring to reality of cervical cancer elimination to those communities that have these higher rates of cervical cancer. So we need an implementation plan to reach these communities, and it's not doing more pap smears in the population that is going to get to the elimination level we need to obtain by 2030. We need an infrastructure plan, so we certainly would call the federal government to come forward and give the infrastructure throughout Canada so we can switch to HPV testing. We have also to look at the committee that will help accelerating the transition from cytology to HPV molecular testing. And in Canada, we have a very good partner named the Canadian Partnership Against Cancer, and certainly could take the leadership in mediating this transition. So conclusions and call to action, and I think it's a very heavy sentence. Is administering the HPV vaccine the best preventive activity of your professional career? And I doubt that there are things that are much better than giving the HPV vaccine in terms of returns, in terms of health for your clientele. So our main issue, again, I repeat, are we delivering to those that need it the most? Are we sufficiently concerned about the situation for the most at-risk population? And I would say no. And these people have the rates of cervical cancer we will see in low-income countries, like some of the Asian countries or the African countries. So we need a plan to reach these high-risk population. And these patients are most likely in your practice. And certainly you need to do sometime an extra counseling to bring women to have a screening, or for young people to receive. But these vulnerable population are those that are the most at risk to develop disease. And I think one of our hurdle is the laziness. We had sufficient successes to rest on our laurels. We're good. People say Canadians are good. You show the example, all that. But it's not now we have to stop. Instead, it's now we have to accelerate, because for us, it's really within reach that elimination goes for 2030. But we have to be aware there are gaps in our successes, there are unreached population, and there are threats around the programs. As you know, cuts are in the healthcare programs are easy to make by some of our politicians. So there are key messages about HPV prevention. HPV vaccine is effective for reducing morbidity from cervical cancer, but it's insufficient to eliminate cervical cancer screening. Cervical cancer screening reduces morbidity and mortality only for cervical cancer. And we have to repeat, the HPV vaccine is safe, efficient, and recommended. So we have to go from planning to reality. Of course, it's a big endeavor to reach elimination, but certainly within the reach of Canadian. So Canada is on a good path to cervical cancer elimination, but we need all of you to be part of the action plan in vaccinating and screening those Canadians that need it. So thank you very much for your attention, and I will turn back the microphone to George. George, please.
Well, thank you very much, Dr. Steben. It was a very thought-provoking review of how we can work together to eliminate cervical cancer in the coming decade. You certainly demonstrated the value of healthcare professionals having discussions with consumers or patients. That really stood out to me. Okay, we're going to move into the question and answer session now. If our audience members have questions, please type them in the questions box and send them in. There's a few questions coming in now, and let me go through them for you, Dr. Steben. One question discusses the influence of the HPV vaccine on the future child. Do you have any information on that?
I don't know if it's about immunizing by air pregnant women. If it's the case, we know that the data that has been shown in animals and the surveillance of women that were inadvertently vaccinated showed that this vaccine is very safe. We don't recommend giving vaccine to women, but if it's giving inadvertently, certainly they would not have concern about the development of the babies. We have strong data about lactation. We know that women who breastfed their kid and had received the vaccine, there was no adverse event that was seen on the mother or the baby from having had received the vaccine prior to lactation or during lactation.
Okay, thank you. Another question about the specificity and sensitivity rates. When you were comparing cytology and hybrid capture 2, were you referring to conventional pap smear or liquid-based cytology with automated screening for abnormal cells?
What I presented is rather a compilation of different studies. I didn't look if they were all cytology or all liquid-based cytology. But when you look at the value of having liquid-based cytology and compared to glass slide smears, there's not a lot of difference in terms of the pickup. What's the main value of switching to the liquid-based cytology is that we could do testing for gonorrhea, chlamydia, we could do HPV testing, and we could eventually in the future also use this liquid-based cytology to do markers. We know that there will be in the future markers of higher risk of transformation toward cancer. So liquid-based cytology is more expensive, and especially if you don't have an infrastructure that has a high throughput, it might be more expensive per case. But as the transition goes to only liquid-based cytology, it will become cheaper because there will be so many different tests we'll be able to do with a single specimen.
Okay, thank you. Another question about prevention. Does the HPV vaccine prevent adenocarcinoma of the cervix?
At this moment, all we know is the data from Finland. We know that in Finland, they had no cases of cervical cancer. And that looks like including both adenocarcinoma and squamous. We know that in all the studies, when you were looking at the high-grade disease of the cervix, it included adenocarcinoma in situ, but there were no cases of cancer in the study. So, of course, because the profile of the virus that we find in adenocarcinoma, mostly 16, 18, and 45, are in the 9-valent vaccine, certainly we would be preventing adenocarcinoma. So we'll have proof maybe a little bit later in the future, but certainly on the precursor, yes, but we have no data yet on cancers.
Okay. Another question about the HPV vaccine. Is there a benefit to offering the vaccine after a sexual assault, particularly in children?
Certainly, there would be an interest in looking in the question. We know that there's a very sensitive issue, and it might be very difficult to have ethical review and consent to do such an issue. But if you ask me if one of my kids would have been assaulted, would I give my kid the vaccine if he did not receive or she did not receive? Certainly, I would.
Mm-hmm. Okay. Now, there's a question about screening. Do you see a potential impact of the shift in screening practices on the diagnosis of glandular lesions?
Certainly, we know that when Dr. Papanicolaou developed cervical cancer screening technique on a glass slide, this was done mostly for squamous cell carcinoma. It took a while for pathologists to understand that adenocarcinoma was also related to HPV infection. So I believe that the shift from the slide, which was not developed to look for glandular lesion or glandular cancer prevention, will be less value than screening for the HPV themselves that are causing glandular lesion or glandular cancer.
Mm-hmm.
So certainly I see that HPV testing will be much more sensitive in picking the precursors or the cancer.
Okay, thank you. We have a more of a policy question. How can we influence the government to understand and act into making this change, that is vaccinating men and women and having HPV screening 2 to 3 times in a lifetime?
I think it will come from expert group. We know that there's a big meeting with the Canadian Partnership Against Cancer in February for World Cancer Day. And I believe that from this meeting about cancer elimination, cervical cancer elimination in Canada, there'll come calls from a group of experts for inclusion of better inclusion of adults in terms of vaccine, as is the case now with the gynecology oncologist of Canada. So GOC is calling for all women that have been diagnosed with lesions of the cervix to be included in the free vaccine program. So we see there's value for the vaccine. Of course, there's the issue of cost. How many doses per year can we have in Canada? I believe also that people will be pushing more and more with once eligible, always eligible. I know in BC it's being discussed. I think it's implemented in some jurisdiction, but some people, especially young people, could not make the decision to be immunized or not, so they were not immunized. But they come in a time in their sexual life where they would like to be immunized, but they're not of the right age. But I think that Canada should have provision in the screening program for those that were eligible when they are always eligible in the future.
Mm-hmm. You mentioned a little bit about catch-up programs, and we have a question here that touches on that. Are you aware of programs to promote vaccination to both young men and women who missed the school vaccinations across universities and colleges?
Oh, there are some here in Montreal. There was a program at Concordia University. Last year, they won a prize at the SOGC meeting about their initiative where they were looking for people that knew about the vaccine but did not get the vaccine but wanted to have the vaccine for a catch-up strategy. We have catch-up in many provinces for various populations. And most provinces also have a catch-up program that is a little bit longer for men who have sex with men and for people who are immunocompromised because they have such a higher burden of disease compared to the heterosexual population or the female having sex with female population.
And do you know if the vaccination is typically free for the catch-up programs?
I think there's catch-up program in every provinces and territories in Canada. But in Canada, we like to be different from our neighbors. So Canada is a patchwork of preventive program. There's catch-up at various ages and various healthcare facilities. And I think it's just to look into your local program to see what are the rules. But many people still need to be immunized. I frequently some women that come to the practice and ask me, my new boyfriend recently had genital warts. Should I be vaccinated? Well, there's no test to say your boyfriend is not contagious anymore, even if he doesn't have the wart. So certainly there are also many people that have immunosuppressive therapy because of transplant, cancer, or autoimmune disease. So these people are at much higher risk of developing disease in the future, should be immunized before they start their immunosuppressive therapy. So certainly there's a lot of people that could benefit from the vaccine, but it will never be free for everyone in Canada or in any other country of the world.
Okay, I'll switch channels a little bit here. Get back to HPV testing. What are your thoughts concerning in-clinic versus at-home self-sampling?
I think we have to consider these programs as complementary. So I think that Netherlands had made the case that including a sent-at-home kit for self-swabbing increase the reach for people who have not been screened for at least 5 years. And I think that most countries of high income will look at this mean to increase the reach for those women that don't want to come for a genital examination in the doctor or the nurse's office. So self-sampling is a reality in the Netherlands at this moment, and I think it's going to spread to many other places. We know that most low-income countries, their screening program are based on self-swabbing at the clinic or at home. So you have the choice of both. So self-swabbing has been proven to have very good results. Women know where their vagina is and are even better than doctors and nurses at doing their own self-sampling for HPV testing. Of course, we cannot do at this moment cytology with self-sampling. We can only do HPV testing.
Okay, thanks. And I've got one different question for you. We talked about the goals to eliminate cervical cancer in Canada. And what would you say would be the first steps that we in Canada could take to eliminate cervical cancer?
I think our major gap at this moment is reaching those vulnerable population. You know, in Canada, it's quite astonishing that we don't have better screening and vaccination services with our First Nations, Cree and Inuit. We know we have population on the street with mental disease or drug consummation issues. So we know, again, these are people in a very high risk of cervical cancer. They don't have a primary care physician or nurse looking after them. We know also with immigrants and refugees, most of them come from countries where there's no screening program at all. And, you know, we don't see billboards on the highway or in the subway talking about cervical cancer screening. So most of these immigrant or refugee women are not aware that there's a life-saving test that can be done. It's called cervical cancer screening. So we have to have specific program for those hard-to-reach population, because those will be population with high level that will prevent us to achieve the elimination goal of WHO. And I think it's a question of equity. I don't understand why Canadians don't have equitable access to preventive services such as prevention of cervical cancer.
Okay, well, thank you very much for that. With that, I think we'll close off the question and answer session. So I'd like to thank Dr. Steben for an excellent presentation and discussion around the questions that our audience kindly submitted. I always enjoy working with Dr. Steben, and I hope our audience enjoyed today's presentation as well. Now, CIDC very much appreciates the support of Merck Canada that allowed us to bring this webinar to you at no cost, and with the assistance of BD Diagnostics and Immunize Canada. Please remember to complete the evaluation by clicking on the link in the follow-up email that you'll receive shortly by email. And as I've mentioned before, the webinar has been recorded, and the video recording and the slide set will be available on CIDC's website soon. These and other resources are available on the CIDC website. You can see the address on the screen there. We're working on our next educational webinar, and it's scheduled to be presented in early January, so please watch for an email notice. Thanks very much for your interest in CIDC educational webinars. We look forward to connecting with you again in January. Goodbye and enjoy the rest of your day.